Don't take it, don't. Don't take it, don't. Don't take it, don't. Don't take it, don't.
Yeah, I've had a long time to work on this talk. It wasn't for sure I was going to come to the conference, and I walked in at about 6:30 last night, and Michael Lerner was like, "Whoa, you're here!" And then within seconds, he cornered me and he said, "Could you give a talk tomorrow?" And so I didn't even ask him on what. It was, and then later we chatted a little bit about that, and then he said, "Well, God, this whole thing's about consciousness, maybe something about cancer and consciousness." And so something's been written that it's about medical advocacy, which I can just touch on and sort of try to tread in that direction. And I've titled the talk, since I don't have any, proud to have no PowerPoint or slides. The title of my talk is A Luddite's Handwritten Field Notes on 7 Still Emerging Trends in the Field of Cancer and Consciousness. And I should preface this by saying sort of who I am briefly. I sometimes enjoy telling people that I'm on independent study from UC Santa Cruz, where I went in the 70s, and you were able to make up your own major, and I did my pre-medical work there, and the year I started was when also someone I'd heard about from my father, who was a psychoanalyst, there was a seminar offered by a guy named Gregory Bateson. And so Gregory's, all this consciousness talk, UC Santa Cruz even then had a department called the History of Consciousness. People get PhDs in it. So I managed to horn my way into, as an undergraduate, into a graduate year-long seminar called The Biology of Culture and Consciousness. So I'm an old hand at this, Michael. Even then, I was interested in cancer because my father was dealing with a kind of salivary gland cancer, and I was doing independent studies on cancer. And I early on realized that there was this bias against things unproven, and there was a ridiculous adherence to what now would be called standard of care. In other words, inflexibility by mainstream medicine. And in seeing my father, who's a physician, have such struggles, early on I was sort of wanting to, there was the guide for fixing Volkswagen vans, or Volkswagens, the People's Guide to Volkswagen. So I wanted to start the People's Guide to Cancer. And pretty much that's sort of what I've been doing for a long, long time. And at some point, I just sort of really threw the tea overboard and just became a medical advocate. And I made this up in about 1988. And the idea was that I was on the side of the patient, fully. Never mind this professional thing that where we doctors are basically kind of there to sort of back each other up. No, I wanted to take the patient's side fully and see where that went. And the work just kept evolving, and I began developing techniques of doing that. I wouldn't treat the patients. I just helped them accomplish what they felt they were missing, or that they had hoped would be done, or that their doctors had actually been obstructionistic or undermining of them wanting to do these things. And so it led to me basically taking directives from patients and their families and being in service to them. And back then it was considered crazy, but I was doing this all remotely, all by phone. And I would hire people to do really deep research for me who were great at, they'd have to go up to the UCSF library and fish around and get the articles. And I would put together these big books of things to teach the patients so that they could come up to speed, so they could begin to advocate for themselves. Because I didn't want to permanently be with their case. I wanted to help them, and then at some point transition out once they were able to carry the ball. So anyway, I've done thousands of patients and learned a lot, and have started different training methods and programs to teach other health professionals how to do this work. And so I get to explore then really the outer realm of the experimental cancer world, this new ideas and development and biotech and all this kind of thing. And at the same token, a lot of the Bolinas wackadoodle whatever, psychedelics old hat. I mean, for real, you used to be able to throw an ayahuasca cactus and hit somebody in the face who will say, yeah, I'll be your guide. I remember one of the meetings we had here, I ran into one of the psychedelic guides. She was walking her 2 wolves over by the Pacific House. So anyway, so let me I'm going to cover 7 things I've learned in the last year that I just thought you might be interested to hear about, and they sort of have to do with consciousness. Number 1, AI. So the major cancer meetings last year in San Diego, the American Association for Cancer Research, this is a smart group, 20,000 or so people, mostly preclinical, early clinical trial, not biopharma as driven. And so they gave over the whole plenary session, to the role of, quote, deep learning. They didn't want to use the term AI, but deep learning. And it blew my mind. I was there with Keith Block, and we were so excited afterwards. It was like having gone and, heard John Coltrane play. We were just ecstatic. And I'll just share with you real simply what this one guy from Germany had figured out. A way of taking a slice through a tumor. So let's say you have a tumor that's, 3 inches wide or something. And so take a whole slice right through it, and then to use different stains and what have you. And what you're interrogating or trying to find is, what is the community of cells and activity within the tumor in the phenotypically in real time. And so, God, this was interesting when it was being presented. So this was really the first maps ever of a cancer. And so what they found was that we've all been talking about cancer as a matter of heterogeneity, that in any solid cancer, there are so many different types of cancer cells that are all sort of labeled as one. You would know it from, say, prostate cancer, where they give the Gleason score, 4 + 3. Well, they're looking at the most common population of cells is the 4 in that case, and the 3 is the second most common population. You can do a Gleason 3rd level, 4th level, 5th level. You can do that for every cancer, breast cancer, lung cancer, colon cancer. The cells are often very different. But in this case, there are all these different cells, but then they would be in different clumps and groups. That they're not evenly distributed, not remotely. They might all be camped on one border, and then there's like nothing going on cancer cell-wise until you get all the way across on the other side. And why is that? Okay, then they've interrogated the cells of the body that have infiltrated the tumor, and what they found were cells, one that in particular that I'm vastly interested in, called the mast cell. But the mast cells, the macrophages, the T lymphocytes, the B lymphocytes, the natural killer cells, the platelets, bacteria, viral particles, they're all purposefully placed in different places in the tumor. And I mean, this is interesting stuff. I mean, really, we're talking about there's an inherent intelligence effectively taking place. And it would be use these metaphors about battle and this and that. And no, it isn't that at all. And it really gives you a different sense of cancer. I've always thought that cancer actually is your body trying to improve something, trying to create something new in an evolutionary sense. And so, yeah, I mean, maybe it is the body trying to redifferentiate the cancer. In other words, make it grow up and behave or be more normal or correct some component of the cancer. I don't know. This fellow from Germany, he didn't know either. But what he was able to show us were these visual images of real cells all in connection to each other, not just crammed randomly. And what he then, he put up his picture of the 30 or so people in his lab who were doing this work. And he said, I know everybody, when they give a talk here, they show their whole team and thank them all for their good work and all that. And they're all part of this paper and blah, 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 blah. No, what he wanted to show was, he said, so everybody standing on the left, they're clinicians. And the other half of the group, they're all IT people. That was profound to me. Not that you would think there's the one IT guy, and it's maybe somebody else if he isn't there or she isn't there. No, we're talking about quantum leap in real time. This was last April. This April's meetings are going to be in Chicago. I'm sure it'll just be up through there. So then people right away would ask questions. Well, can we, do this as a service to a patient? He said, yes, we can. Wow. Really cool stuff. And I said to Mike, well, I might touch on AI, and I said, and don't you think AI has to do with consciousness? Well, these are fair questions. Ask William Gibson, sci-fi. I think it does, especially if we're the ones asking the questions and then looking at the answers and then going even deeper. And this is the research process I follow on every case I work. So AI. Number 2, I mentioned mast cells. You may not know this, but the first national meetings ever held on mast cell activation syndrome were held right here at Commonweal. I organized it in 2018, and everybody here was kind of bewildered. They'd never heard of mast cells for the most part, and then I'm sort of looking around. And the thing about mast cell activation syndrome, turns out, pretty good studies, about 1 in 5 people have it. That common. 85% run in families. You can usually see the signal for the problems, the symptoms early in life. Mast cells are something that are part of the immune system technically. They're made in the bone marrow, and then they spread out when you're born basically, and they take up residence in all the soft tissues of the body. So like the things you have on your skin, so if you go walk out there and you get exposed to poison oak, so what is it in your skin that's going to make the redness and the itching, the rash? Those are mast cells. For example, they're protecting you from things you might touch upon. You get stung by a mosquito or a bee or something, that kind of swelling, anaphylactic, explosive immune reaction, mast cells. Similarly, it's interesting, if you swallow something like a poison or something, and how does the body know instantly to make you throw up or give you diarrhea? Mast cells. The mast cells just line your stem to stern through your whole GI tract. They're in profusion. Turns out there's loads of mast cells in the brain, floating around in the tissues, and we don't have a clue what they're doing there. There's mast cells positioned along all the major nerves in little clusters, and they're literally like sentinels. And they're reading the signals, say, coming from the legs, going to the brain, and they have the ability to tamp them down or to accelerate and broaden them. So mast cell is basically a disease of multi-systems by definition and of inflammation. Universally, it's about inflammation. And again, if you just want to think simply what is mast cell about, it's synonymous with the word inflammation. And in the field of cancer, we all endlessly talk about inflammation-driven. These are things that promote the cancer. And mast cells are pretty darn interesting that way, in that they can participate in that. But more to the point, I find that in the work that I do with mast cells in relation to cancer is that people are often reacting to chemicals, the chemotherapies, the targeted therapies, the radiation therapy. Mast cells are in charge of, say, tissue remodeling, making a scar if you need to make a scar, or lengthening. There's a big overlap between mast cell activation syndrome and so-called hypermobility or Ehlers-Danlos syndrome. There's a big overlap. The same idea in yoga. So these people who can stretch out and put their palms on the ground, all that, they have a different set of mast cells. It's quite interesting. But I began to look at my cancer patients, people with advanced cancers, not all, but complex cancers. And when I would take a mast cell activation syndrome history, 50% of them rule in. And that's relevant both as to a possible add-on strategy to help the cancer stay in remission or not, or be under better control. But more practically in the here and now, I find that working the mast cell angle by giving mast cell inhibitors, which are antihistamines, over the counter, type 1, type 2, Zyrtec, Allegra, Zysol, Claritin, and then type 2 being like drugs like Pepcid or Zantac. So I reasoned, this is just my idea, that you could maybe then prevent some of the toxicities of the chemotherapy and some of the long-term consequences of fibrosis, say from radiation. So I've been working this angle pretty regularly. And I have to tell you, it makes a huge difference. Huge difference. These patients don't have to dose reduce as often for the chemotherapy, or they don't have to miss doses because of the toxicity. And the other piece of it is, everybody talks about chemical sensitivity and your body burden of chemicals and the environmental period that we live in. A huge, huge factor is what are called excipients. And these are the inert or the inactive compounds in every prescribed and over-the-counter drug. These are chemicals added in, said to be inert, but they're for appearance, preservatives, red dye number 7, blue dye number 4, whatever. They're there for binders. They're there as emollients so that you can swallow these things better. And so every drug you might ever think to take, you can go online and look up these inert or inactive things. It's called Daily Med, all one word. And then you go in there and you punch in whatever drug you want to look at. To give you an example, if you want to enter the word, say, metformin of interest for cancer, you'll find 500 different metformins out there, 1 million different companies making that drug, and different combinations with other different doses. But boy, then you sort of scroll around and look for under ingredients and appearance, and that's where you'll see the list of all the garbage in these drugs. And it's really, I haven't even broached this yet, but there are similar excipients in the chemotherapies, the targeted therapies. And, if there's a major movement that could make a big difference for people, I think, and there's certainly a lot of people wanting this, it's working more with compounding pharmacies to create clean drugs that don't have all these add-ins. And you can tailor them to the person and what they know are chemicals or compounds that agree with their system. So that's a practical side of the mast cell thing. On the histamine side, which is the main compound that mast cells are known for, by the way, mast cells produce upwards of 1,000 different chemical agents, the hormones, neurotransmitters, basically all the inflammatory molecules that would ever drive any inflammation. So histamine is the one it's best known for. How interesting. There's a big study that just came out of Scandinavia. They looked backwards. So the great thing about people with nationalized health insurance, really good data on their population. So anybody who's ever gotten a prescription for anything, it's a record there. And then they can follow them, or they retrospectively, prospectively. Women who had taken antihistamines during their life had about a 50% lower rate of ovarian cancer. That's a lot. Yeah, that's a lot. So I am recommending, though, that we begin to liberalize our views on using some of those compounds to be used in cancer care, trying to get cleaner drugs, so-called free of the excipients, these add-ins. Another study that came out of Scandinavia was looking at people who had colorectal cancer, advanced colorectal cancers, who got into remission and then for whatever reason needed to travel to Bangladesh or somewhere, and they would need a cholera vaccine. For whatever reason, these researchers, their names are the Sundquist, S-U-N-D-Q-I-S-T. They, again, perfect data set. They can go and look at people who ever got the cholera vaccine who had advanced colorectal cancer. 2 doses oral cholera vaccine, different than the one we use in our country. They had a 50% improved survival or reduction in recurrence. And the data was so stunning. They then went and looked for prostate cancer. Same story. Had prostatectomies, whatever, just wanted to see if it recurred or if they ended up dying of prostate cancer. It was the same figure. 2 oral doses of a cholera vaccine, 50% reduction for prostate cancer. And then more recently, they looked for breast cancer, same exact number. This is easy stuff. You can't get it here. I send people, some people in the room, I'll say, look, great time to go visit Vancouver, because they have the same vaccine up there. You can get it over the counter. It costs about $100. It's called Dukoral. And you get 2 doses of this cholera vaccine. And what all these 3 studies on those 3 cancers have in common is they're all adenocarcinomas. So I think you could reasonably extend the strategy to virtually any adenocarcinoma. These are easy add-ons. I sort of like do-it-yourself immunotherapy, adjuvant immunotherapy, however you want to put it. 2 last things. Keith Block, were he here, and I wasn't having to fill in and fill his time and sort of give some cred for ballast, some quasi-cancer doctor. But the coolest thing Keith Block ever hit on and has made the biggest difference is chronomodulated chemotherapy. And that, again, relates to a lot of what I'm speaking of. That means for every drug you can think of, there's a circadian window of about 2 to 4 hours when if you give the drug during that time, you name the drug, somebody has figured out that window, where you will have, if you get that drug then, it'll work better and with less toxicity. And so a guy named Francis Levy, L-E-V-I, in France, set up some huge studies, multi-site studies, large numbers of patients. And he figured out for colorectal cancer first, if you do 5-FU and give it at 4 in the afternoon compared to 4 in the morning, at 4 in the afternoon, it's twice as toxic and 1/2 as effective compared to if you have a special pump that would, while the person's sleeping, it'll run in and is programmed to give it at 4 in the morning. These are big differences, big differences. And by the same token, now there's data not through Keith on, so the most common immunotherapies being given now are like Keytruda or Opdivo, these so-called checkpoint blockade inhibitors, the PD-1, PD-L1 inhibitors. Turns out, if you give that drug or run it into the patient in the afternoon, but certainly by 3 o'clock, it reduces the chance of it being effective by 80% compared to doing it in the morning. So the circadian piece, I think, is really remarkable. And for any chemotherapy you might imagine, it's been worked out or figured out or approximation of what the optimal window is. And then the last thing I want to say that I've just kind of really been fascinated by. So patients can decide for themselves they want to get a whole body MRI. This is discouraged in the major medical centers, but you go to Pronuvo, it's down the peninsula in El Camino Real, you pay about $1,800 and you'll get this whole body MRI. And you get, are you just looking for trouble or who knows what? No, probably not. These are people who kind of have reason. And back to the mast cell thing, there's a phenotype, there's a type of people with mast cell activation syndrome. They just grow things. You take their history, they have lots of little benign growths and ovarian cysts and polyps in their colon and things in their thyroid. On their skin, all kinds of lipomas, and they grow things. So I'm having an amazing time getting this done with people. And the MRIs are read by AI. They're overread by some radiologist. But oh my God, you'll be amazed. There's these things in the liver, in the spleen, in the kidneys, in the you name it, and it is worth knowing about, because if you are a person, nobody has really closed the full loop on this angle I'm proposing here. But if you do have mast cell activation syndrome and you're one of these people who grows things, it's fair to know that. And then you begin to either screen differently. You won't get your docs supporting you going to get it. You'll end up just getting it on your own. Many of the people who I did this with, they were physicians. In Europe, they use whole body MRI a whole lot more. So how does this deal with consciousness? Michael is always happy to have people propose new words that might better describe. And listening today, even, I don't think we have the language, the words, and you hit at it in some of your ways of trying to find it. How do we talk about this? And I just am remembering, and I was completely happy with Rachel Remen just calling it the mystery. I really am. And in looking at sort of, Aboriginal culture and Native Americans, they just call it the dreaming. So I'll leave it at that.
Don't take it, 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 don't take it,